So good evening, everybody. Welcome once again. We are now just officially starting, and I would like to request Lillian to open for us with a word of prayer. Lillian?
Good evening, everyone.
Good evening.
Okay, let us pray. Our Heavenly Father, we thank you for this beautiful evening. We thank you for being with us throughout the day. Father, thank you for the gift of life. Thank you for everything you've done to our life. Father, as we start this meeting, this webinar, Father, we ask you to be with us, be with the caregivers and even the panelists who are going to talk, dear God. When we finish, Lord Father, we shall thank you and glorify your name, for we pray in Jesus' name, we pray and believe.
Amen.
Amen. Amen. Thank you, Lillian, very much. We do appreciate that. So welcome to every last one of us. It's yet another beautiful evening that we get to meet together, to learn together. And today we'll be discussing about autism and epilepsy. So it's an honor to have you join us. We hope we will learn one from another. Feel free to engage and participate. With us today, we have Dr. Eddie. Dr. Eddie Chengo. He will be introducing himself a bit later on. And we also have with us Ruth, who is a caregiver, who will be sharing her story in just a bit. Before I invite Ruth, I would just like to give you a brief background of who we are as Gifted Gems. Some of you, this could be the first time that you're encountering us. And once again, karibu sana. So we are an organization that deals with civic education on autism. We raise awareness. We provide psychosocial support to caregivers. And we also provide basic skills to caregivers as well. Our clarion call is early intervention. And that is why we endeavor to do this, so that we can be able to educate the caregiver, inform the caregiver, and then the caregiver can be able to make informed decisions and actually have early diagnosis and early intervention. And that can make even the autism journey more and more, a little bit easier. So welcome to every last one of us. As now we're about to go to the topic of the day, I want to introduce Jane, who is a caregiver. Jane, thank you for joining us and for accepting to share your story. We really appreciate. Please tell us who you are, give us a little bit of your background, and then we'll pick it up from there. Karibu, Jane.
Thank you very much, Carol. My name's Jane Nyanchama Mokua. I've got a teenage boy who has autism. He's 21 years. He's called Ryan Matthew Monari. And at the same time, I take care of my sister's daughter who is epileptic. And she's 48 years. We've been through all this journey together. In fact, I grew up together with her. We are very close. So it's a journey. I've seen how epilepsy can really be bad, and it gives a lot of problems. So since childhood, I've grown with her, taken care of her. So I've seen all these things happening, and the feats and all that happen. So it has been quite a journey. But all in all, she takes her medicine, and What I can say actually is when they grow older, it becomes even worse. Because right now it's like she's not very, very mentally stable. It's like she's losing it a bit. And when they get older, if you didn't give them a really stable thing to do, they are so bored. Like
Jane, we are losing you. Okay.
Yeah.
Okay, Jane, sorry, we are losing you.
Sorry?
We had lost you earlier on.
Oh, so you didn't even hear what I was saying?
Yeah, towards the end.
Oh, towards the end.
Yes.
Yeah, where can I start from? Where didn't you hear?
Maybe you can start from if you didn't give them something stable to do.
Oh, okay, yeah. When they don't have something stable to do and keep them busy, towards the end, it becomes so tough for them because they're idle and they also want to be busy and do something. So it becomes a challenge, a big challenge. That's what I've noticed when I take care of my sister's daughter.
Okay. Thank you, Jane. Maybe I could just indulge you a little bit. When
Yes.
in the journey, what exactly did you note? What have you been seeing? Like when you say epilepsy, what exactly have you been seeing?
What I've been seeing is when she's very, very excited, maybe we're coming up with a birthday, there are some visitors. When she's anxious, she gets a lot of the shizas. During the journey, that's what I've noticed. When she's very happy, or again she's very low, sometimes that is when she gets the fits.
Okay. So when that happens, like what have you been doing when she gets the seizure?
Now,
What?
during the beginning, during the beginning when she started, when she was young, we were not quite well informed because she used to bite her tongue very much and she used to lose a lot of blood. So what we used to do is to take a spoon, tie it maybe with a soft cloth, and then during the feet, the scissors, we could put it, trying to suppress the tongue. And I think we never used to do the right thing, but we didn't know what to do because she used to bite the tongue a lot. But with time, it actually went down a little bit, it stopped, and we stopped doing that because we were told it wasn't the right thing to do.
Okay, so what now have you been doing instead of the fork?
The spoon, the wrapping, we stopped putting it, but I'm saying with time, she stopped biting the tongue.
Okay.
Yeah, so it came a little bit better.
Okay.
Yeah.
Well, that must have been tough. We hear you.
Thank you.
Yeah. So you also spoke about medication. When did she start like medication? And then who did you probably go to for a diagnosis?
Oh, there's this doctor who passed on. I've just forgotten during Corona time, a very good doctor. So unfortunate, I've forgotten the name. But he passed on. He's the one who has been seeing her. She's been taking a medication. I don't stay with her. I always just visit. But she's been taking medication all over during all the time, ever since she was young.
Okay. Thank you, Jane, for that.
Thank you.
Okay, so I want to bring in Daktari because this is quite a heavy topic. And I just want, Daktari, I want to bring you in. Karibu sana.
Asante sana. Can you hear me?
Yes, we can
Yes.
hear you. Kindly introduce yourself and we pick it up from there.
I hope you can also see me.
Yes.
Not in flesh and blood, of course.
Okay.
So, yeah. Sorry, just a minute.
Maybe your volume a bit. Okay, let's just give Victoria a few minutes.
Okay, can you hear me now?
Yes.
Yes.
Okay, I think my mic had a problem. Can I allow me to change my earphones because I really need to shout and I'm not using the earphones. So just a minute, I'm just taking them from the other table.
Okay. As Dr. Eddie does that, please feel free to engage. Just raise your hand or type in a question. We should be able to get to him. He should be able to respond. And it's our prayer that at the end of this session, we will all be well informed and all the questions we have, time allowing, will all be answered. So feel free, let it be very interactive.
Okay, I guess I just need to shout. I've just changed the earphones, but it's not working. Yeah, so you are saying, Carol, that I need to introduce myself or to
Yes.
reintroduce myself. I think I'll do that. So I am Eddie Chengo. I work with Foundation for People with Epilepsy, and I'm an epilepsy specialist. My background is clinical medicine. I started working in epilepsy care from the year 2003. I got an opportunity to work in a research-based organization, and we did a lot of epidemiological studies on epilepsy in Kilifi County. That's where I am based. And now I work with Foundation for People with Epilepsy, still doing research, still doing clinical work, and also doing epilepsy awareness throughout the country. So that's our core mandate. That's it. I'm very passionate about epilepsy, and I had Jen saying something that really touched me about the sister that she's actually. I think the description is like she's getting worse, but I think there's something that can be done. I want to believe there's something that can be done because if you have a better control in most of the epilepsies, you get better with time. Most of the epilepsies, around 80% of the epilepsy, will be easy to control, and most of the epilepsies also will not have a lot of coexisting morbidities. If now is 43 years, as you said, then there is a chance that probably some of the issues can be addressed and she can get better. So maybe if you allow me, I share my screen as I proceed, or if maybe you need to say something else before I continue.
Yeah, no, please share.
Okay. I think you've disabled the participant screen sharing, so you need to
It's good. It's good now.
Okay, it's okay. Right. Can you see my screen?
Yes.
Okay, perfect. So today we are going to discuss about epilepsy and autism. And there are a lot of similarities when it comes to some of the presenting features in epilepsy and autism, and most of the time they co-occur. So I think it's good just to share, the background, share some of the symptoms, and probably answer most of the questions that the parents were asking about autism and epilepsy, in terms of their presentation, in terms of management, in terms of the care process, in terms of how to handle children with autism spectrum disorder in school and probably even at home. I'll also need to learn from the parents as well and the caregivers and most of you, because my specialty, as much as it's in neurodevelopmental disorders, but I've majored in epilepsy. So I see a lot of these cases, but there are some experiences that we would also like to learn from the parents. I learn every other day in the clinic when I see people with epilepsy, when I see people with parents with children with autism. They tell me something that, when I listen, I learn about something new that probably empowers me or enriches my knowledge. So without taking much time, all right, I need to put in slide. So, okay. Sorry, I just need to restart again, and then.
Awesome.
Sorry about that.
No problem.
Uh-huh. Something is. I can't do slideshow. I can't do it in presentation mode, so I think I'll have just to go slide by slide. So the outline of my presentation will be probably I'll just define epilepsy and autism, the risk factors, the management, and the practical ways to enhance care. So yeah, so autism spectrum disorder is diagnosed when only the characteristics deficits of social communication accompanied by excessively repetitive behaviors, restricted interest, and insistence of sameness. And I think I just described further on this. When we talk about persistent deficits in social communication and social interaction across multiple contexts, as it will manifest in the following areas, and that could be when you talk about the social, emotional interaction, either by history, will be abnormal social approach, failure to normal back and forth conversation. They may not be able to respond to names. They may be having poor eye contact or impaired of body postures, or sometimes they may face away from the listener. So they look as if they are in their own in their own world. And when you talk about the restricted repetitive patterns, will be probably the stereotyped repetitive motor movements of, say, use of the same objects, speeches, or some jargon of some kind. They would sometimes even clap, the same way, which has the same pattern rather. So all these symptoms, most of the time, would clinically, or significantly impair the social, occupational, or other important areas in their functioning. So when it comes to epilepsy, epilepsy is a disorder characterized only by enduring predisposition of recurrent seizures, but not explicitly to neurobiological, cognitive, psychological, and social consequences of the condition, as Jen had earlier reiterated that, there are a lot of things that the sister is going through. It's not just the seizures, she gets bored when she's not involved. She's sort of like in a cage. Psychologically, from the way, Jen was describing, seeing the sister is also psychologically disturbed, probably because of the social interaction and so many other things that come with epilepsy, because seizures is just the tip of the iceberg. There are so many other things that come with epilepsy, the restrictions, the anxiety that comes with seizures, the fear, the stigma, the discrimination, and this forms the bigger burden of epilepsy. Even the seizures themselves could not manifest as bigger problems than the social or the psychosocial aspect of epilepsy. So the practical definition of epilepsy is 2 unprovoked seizures. So the seizures have to be 2 within 24 hours apart to be called epilepsy. Or sometimes you can have only 1 seizure, but if you have a 60% chance of having another seizure, then we can start treatment on such a person. And also maybe a diagnosis of an epilepsy syndrome, as we will see when we are talking about other syndrome that can manifest with autistic features. So a seizure is not epilepsy. People can have seizures, but not necessarily epilepsy. It's just an event, but epilepsy should be repeated and associated with spontaneous recurring events. And that then we will call epilepsy, and they should be unprovoked. Now, epilepsy compared to autism, epilepsy can resolve in some people. And we say that epilepsy is resolved when you have had 5 years of seizure freedom with treatment and 5 years of seizure freedom without treatment. So that's a total of 10 years without seizures. And then we can say that the epilepsy has resolved. We can stop treatment and try if you can, of course, not get others. There's a smaller percentage of people who sometimes can relapse, but most of the people after this period of time, they will be seizure freedom for the rest of their lives. And of course, we use the word resolve to just want to avoid the word resolve, so that because resolve has the connotation of no longer present, but that's not really true when it comes to epilepsy, because it may come back again. So what do caregivers say about these conditions? I think that's the thing, because most of us as clinicians will not, we already have some way of of making some decisions, sometimes even without listening to what the caregiver is saying. Because what you think epilepsy is to the caregiver or autism spectrum is that the thing that really matters to the caregiver should be the one that should also be addressed. As much you want to address seizures, as much as you want to address this abnormal behavior, this speech problem, you want to do all these therapies. But what about the parent? What does the parent say? And I think as you think through, most of the people will define epilepsy or these conditions in their own way. So for example, people would say unpredictable, mysterious, misunderstood. Some of them would say emotionally driven disease, terrifying, annoying, tiring, mind-blowing disease, brain under attack, scary, tiring, hopeless. It's a monster. It causes detachment, it's confusion, it causes sleep, shakes, all these things. And I think when we listen to our parents, when we listen to our patients well, then we'll be able to address what really eats them up in this condition. So as much as we have defined in our own way as a seizure, as a condition that causes communication, social or restricted behavior, that is true, very true. But what about the parent? And that is what we should address most. I put this slide specifically because some of the symptoms in epilepsy can actually present like autism spectrum disorder. This is why I put this slide here. So these are some of the epilepsy types, the classification of epilepsy. And some of the focal seizures, for example, patients presenting with behavioral arrest, that can be mistaken. Even patients with autistic behavior sometimes can have behavioral arrest. They can just stare. They can have cognitive features. They can present with sensory features. And sometimes this can delay the management of epilepsy in patients who have autism spectrum disorder. So, and that's where sometimes the confusion can be. And we need to listen carefully. We need to see, because another thing is sometimes, of course, epilepsy occurs quite common in patients with autism spectrum disorder. But if you're not careful, you might overtreat or you may undertreat. So in autism, these are some of the features that happen that mostly, apart from the convulsive seizures, which are tonic-clonic seizures, features like blank stare, they will just go blank. They won't respond sometimes. They won't look at you. And this is a very important feature also in epilepsy. Some of the epilepsy, especially in children, like childhood absence epilepsy, even atypical seizure, absence seizures can present with blank stares. Loss of focus, the cognitive seizures that can present with inattention and unusual movement, and also tics, the sounds that sometimes children with autism spectrum disorder can have. The repeated sounds and movements sometimes can be confused either with epilepsy, or they might be missed and yet they're epilepsy, and the unusual sensory experiences as well. So I'm going to talk about the risk factors of getting, these conditions. They're one and the same. Actually, the risk factors for getting epilepsy are also, some of them are also the risk factors for getting the autism spectrum disorder. So for example, in prenatal, the maternal folate, it's important. And many studies have shown that the children who have their mothers did not take folic acid, sometimes they can have other disorders, even the spina bifida and other neurocognitive disorders that can also result into autism. Infections during pregnancy, for example, like rubella, which is associated with intellectual disability and autism by association, epilepsy as well. Other medication, for example, mothers who have epilepsy and they're taking valproate acid in high doses can also predispose these children to have, apart from epilepsy, also they can have autism spectrum disorder. Brain damage during delivery, and metabolic conditions and also genetic disorders also can predispose to both epilepsy and autism. So you find that the risk factors for getting epilepsy are also the same risk factors that sometimes can also predispose to autism spectrum disorder. So there are questions that parents would probably like to know. And one of the questions will, does epilepsy cause autism? Now, this is a difficult one. But of course, I would just like to mention a few epilepsy syndromes that basically can present with autistic features. For example, one of the syndrome is called, and kindly parents, these words are medical words, they seem like jargon, but kindly just take the message, and the words, if you can't, you know, they just, I just want to present the relationship between epilepsy and autism. So there are syndromes in children that can cause regression in language skills, behavioral difficulties, sometimes with or without history of epilepsy, after normal language development. And this syndrome can also present with an abnormal EEG findings. Now, the autistic features here are clearly as a direct result of the epilepsy, because when you treat this epilepsy type, the Landau-Kleffner syndrome or the acquired epileptic aphasia, then you'll find that there is some progress in some of the symptoms, like some of the autistic features. And also this other syndrome, the continuous spike and wave during sleep, can also present the same way. And when you treat these syndromes, then you will find that some of the autistic features can also resolve. So what am I saying here? We should, as parents, be very careful and observant. When a child loses any skill, you know, it's important that we take them to for review and take time with the doctor and explain, you know, what is happening to your child to the doctor. And then the doctor will be able to see or diagnose these conditions at an early stage to avoid, you know, further complications that come with these conditions. Does autism cause epilepsy? The simple answer is no. But of course, people say that, you know, it causes some because of the symptoms and that kind of thing. But the consistent of autism and epilepsy is association and not as a causation. So the relationship between autism and epilepsy in terms of treatment, as I mentioned earlier, and the other slides, the treatment of some epilepsy syndrome may allow some skills to return and reverse some of the autistic features, for example, the LKS and the CSWS. So that's the relationship in treatment. Of course, some of the things that can happen also in autism, especially for those who require a lot of support, for example. So there are some medicine also that can be used to allay anxiety, for example, like maybe risperidone. There are some other authorities that have tried even anti-seizure medication to treat the moods in children with ASD or autism spectrum disorder. So some of the anti-seizure medication that have been tried in some quarters, you know, really a lot of some research needs to be done. But of course, I can imagine that, you know, if it works for that patient, especially like, for example, like sodium valproate has been tried to stabilize the mood in some children, and some parents have reported like a positive result in such cases. So what about the outcome of autism and epilepsy? So autism spectrum disorder is basically a pervasive disorder, so it's constant over time. However, the way it affects the quality of life is influenced by intellectual disability. So the more severe the intellectual disability, the more the symptoms of autism spectrum disorder and epilepsy. Lack of communication as well, environmental factors, reaction to individual to the individual by other people. For example, people will not let them be, and yet at that point in time, really, and I think if we have parents and caregivers here, I think sometimes when you let them be, then you will avoid a lot of, disruptions. If you let them play with that toy, if you talk to them in a way that, you have been trained to, you avoid that. But sometimes other people will not do that, and then it will really affect the outcome of this condition. So these epilepsy types, when treated, can greatly reduce autistic features, and intellectual disability affects both conditions in terms of severity, as I said earlier, and sometimes there are delays in treatment of epilepsy because signs and symptoms may be similar, especially those with cognitive features in focal seizures or focal epilepsies. So what's the treatment of epilepsy in autism? Number one, all these conditions are clinically diagnosed. There is no, apart from epilepsy, which sometimes you may require an EEG, which is a test that helps in diagnosis of epilepsy. But apart from that, all these symptoms, all these conditions are clinically diagnosed. So we have to listen intelligently, examine, and investigate appropriately. I think that's the secret. So the management starts from that diagnosis, that clinical diagnosis is this autism. So when that is done, then the general principle is, do we need some medicine here or not? Because some of the patients with autism and epilepsy, of course, if they have epilepsy, anti-seizure medication will be there. But if it's autism without epilepsy, then the therapies, the behavioral therapies work even better. So in epilepsy, if they have epilepsy, then truly drug efficacy doesn't matter. No matter how expensive or good, quote unquote, the drug is, it doesn't matter at all, because if it doesn't work for that particular patient, then the drug should be changed. Not all patients, not all people respond the same way with the same drug. So if a drug doesn't work, we need to change to another medication. If the drug causes any side effect, then we need to change that drug, because tolerability and long-term safety must be paramount in treatment of autism and patients with epilepsy in epilepsy. So the choice of anti-seizure medication in this newly diagnosed, probably we have to pick a drug that has a wider spectrum and fewer side effects. Of course, because some of the seizure types in patients with autism, they could have multiple seizures. And therefore, we need to have a good drug that we have after the clinical diagnosis that have a wider spectrum that can produce seizure freedom without a long-term sequela. So we can avoid drugs like barbiturates. Barbiturates parents, it means drugs that can cause some side effect of, say, they can allay anxiety in a way, but for children, for example, like phenobarbital, that will not be the best drug. So we need also to match this medicine according to the age, according to the epilepsy syndrome, sometimes according to gender, according to weight, other psychiatric comorbidities, and also teratogenicity. And then more importantly, we need to consider cost, because some of the drugs can be very expensive. We can prescribe these drugs to parents on paper, but practically they cannot be afforded. And then it can also cause more distress to the parent. So if two drugs, anti-seizure medication, for example, fail, we need to make sure that we improve that seizure control and probably the other behavioral issues that this patient have. So the aim here is to reduce the drug load. Of course, some of the patients with autism, if they have epilepsy, they can be very difficult to take medicine. We should be preview of that. And therefore, we have to choose also a formulation and not very many drugs, which of course, we need to also see that the seizure frequency and the severity is also reduced. And more importantly, improve coexisting problems or difficulties. So we know that lower doses work effectively as well as higher doses. So low dose by therapy may be better tolerated and more effective even compared to higher dose of one medicine. So what I'm trying to say here is the secret here is to understand our children well. You know, sometimes children with autism, and if they have epilepsy, they may be having seizures that maybe happen like 2 or 3 times in a month, or sometimes even more. And they could be triggered by something. And when they are triggered by something, it doesn't necessarily mean that this medicine is not working. So let's also observe for triggers. For example, children who have autism and they have the hyper sensory effect, you know, they don't want to hear noise. There's something that can trigger them, and then they have more anxiety, and then, you know, they get seizures. So if you avoid that particular type of noise, then clearly the seizure frequency will go down. So you will not need a lot of medicine. But if every time we don't talk about that seizure, that trigger, then we're going to give more medicine, you're going to change more medicine, and clearly sometimes it may be having more harmful effect than the beneficial effect. So I want to conclude in terms of the drug treatment that for all patients with epilepsy and autism, we need to consider the side effects. We need to consider, you know, sleep and other occupation. We need to consider their mood. We need to consider weight gain. Of course, you know, I won't want to talk much about sexual function, but this is more into the epilepsy thing. And lastly, the holistic approach is recommended in using a wide range of anti-seizure medication. So I just want to wind up by talking about the role of multidisciplinary team in management of autism. Autism spectrum disorder and epilepsy requires a multidisciplinary team. And this is because epilepsy and autism have significantly more likely to report at least one or more comorbidity. So they'll have intellectual disability. They may be having some other forms of disability that may require, you know, other specialists to come in. So we need specialists here. We need clinician specialists, you know, epileptologists. We may need neurologists. We may need psychiatrists. We may need social workers, psychologists, from the nutrition, the nurses, the social workers. All these are needed to provide education to the parent, to do the behavioral therapies, you know, that are going to help the patient, the children, and improve the quality of life of the family as well. For clinicians, sometimes also we may need to start drug treatment, especially if the children are so much affected with autism and seizures. So we need to keep on changing treatment until we achieve a good seizure control without side effects. So epilepsy and autism care should be multidisciplinary and long-term. We have to link primary and tertiary care and educate family to improve management of children. So these are the practical ways. When we go to the doctor's office, let's be calm. I know sometimes it's a little bit difficult. We've had a lot of bad days. We've had a lot of difficult days. And when we are in that room, sometimes we feel that we are wasting time, or maybe the doctor is having a queue. So, you know, you want to say everything in one sentence, and that will not work. It has to be a two-way discussion. You have to calm down and explain to the doctor step by step. You know, that is going to help. And also for us as clinicians, we need to do the same. we need to listen intelligently to the patient, because only the patient knows what they feel. They know what side effects are bothersome. They know how many seizures are too many. They know what behavior bothers them most in this child. I've had parents saying that, they come with the children with autism spectrum disorder, but they say they don't care so much about that noise, those tics, that behavior that will be bothersome to other people. To them, it doesn't bother them at all. So I think it's important for us to listen intelligently, but more importantly also, as caregivers, let's also have time and explain to the doctor what we feel and what our expectations are. So for the doctor, listen intelligently and examine the patient. Now, two, in epilepsy and autism again, of course, try multiple anti-seizure medication. If one doesn't work, we need to go to another one. If that one doesn't, if one causes a side effect, of course, we need to change to another one. We need to switch. And this should not take very long. We need to offer timely alternative for patients with these conditions, because if we stay for too long, then the obvious can happen. They give up and they think that, this will never work. And then the patients, don't get the quality of life that they deserve. Of course, individual patients respond differently to anti-seizure medication. So if one doesn't work, there's no problem. You just need to change to another one that will work for that patient. So it's the same story. If even two meds don't work, we need to change to another meds. We need to change. We need to keep on changing timely until we get the right one that works for that patient. Sometimes it can even take a year. So parents, don't give up. Don't give up. If it doesn't work, just keep on telling your clinician that, what, I've tried for the past 1 month, but I think my child is not getting better. My child is getting rashes. My child is getting more tantrums. My child is getting too drowsy. My child is not playful. And then an alternative will be given. So access to specialty to treat comorbidities, as I said, it comes, we need a multidisciplinary team. So access to all these people is important. The neurologists, the psychiatrists, epileptologists, the social workers, the nurses, physicians sometimes can also come in to treat other metabolic diseases that come that can cause these problems. So epilepsy care should involve multidisciplinary team and refer patients for assistance when you identify a problem beyond epilepsy, for example, like depression and the others. So in the clinic setup, we need to utilize other staff as well. That's very, very important, so that they can help manage. So the nurses, the receptionists, sometimes patients are more freer, to the receptionist, and they can tell them something that is distressing them at the reception. And when they go to the doctor, either because of time or whatever, I think our culture is a little bit detects that, the doctor is the boss. So sometimes they feel more freer to the people outside or the nurse. But that helps. So when we work together as a team, then the patient gets better care. And more importantly, and finally, support groups. Support groups really, really help, both in epilepsy and autism, because the sharing, the experiences, what worked for me as a parent, the journey, sharing the journey is very, very important. It really helps us to learn a lot and probably, make better decisions as we take care of our patients. Thank you very much for listening.
Thank you so much, Daktari. We do appreciate the insights. And at this point, I want to, before I bring in the questions, and I see, there is already one. What can be done if the anti-seizure medication keeps going out of stock? Is it practical to keep switching anti-seizure medication Okay, let's just do the question, then I'll bring in what I also wanted us to talk about.
Okay. I understand, and that's a very practical question. Sometimes anti-seizure medication gets out of stock, and as clinicians, we should also understand, what we are really prescribing. It's not fair. I would say, let me be a little bit harsh, but I think I should say that, to prescribe a drug that is not available, or it's very, very expensive if there is an alternative, So I think we should go step by step first. Start small, what is available, what is affordable, or effective rather, not affordable, but I think I should use the word effective, and then we can do that. Of course, it's not good to switch medication from one medicine to another, but we only switch if one is not working. I will switch the medicine if it is not working, or if it causes side effects. So if it's not bringing good effect, or if it's causing side effects, then we have to change that medicine. I hope I've answered your question.
Do you need further elaboration?
Sorry?
I'm asking our participant whether that is sufficient.
Yes, that's sufficient. Thank you.
Okay, you're welcome. Thank you for the question. Please keep them coming. Anyone else with a question? You can raise your hand or unmute yourself. As we wait for a question, I do have, I want to indulge you a little bit. So please, if maybe you can just put your video on, I want to ask a descriptive kind of question, because for some of us, it could be the first time. So when you have your child at the toddler age, where, if you're talking about staring, how do I know that my child with autism is just staring, and what kind of stare? Maybe if you can just give us an example. We see, is it just staring in space? Is there a form of staring? How will I know as a caregiver?
Okay. As I said, it's a little bit difficult, but normally a blank stare. A blank stare that is unresponsive is more likely to be a seizure. And then they will respond after that, either appropriately or inappropriately. But those blank stares, again, should be frequent enough. Sometimes if they're very minimal, you will probably say that is part of the autism spectrum disorder, presentation when they become inattentive. But I think when it's so much repeated, then then you can start worrying, and probably other investigation needs to be done, like an EEG. And most of the time, the EEG should be long-term, because most of the studies that have been done, have shown that people with autistic spectrum disorders have abnormal EEGs compared to the general population. So even if they don't have epilepsy, they will have abnormal EEGs. So you really need to rely on the clinical symptoms. So they should be enough to cause, a disruption. Sometimes, for example, I would say language disorder in patients with autism who have a language disorder. And that's a presentation, but you can't put those two diagnoses as this is a language disorder and autism spectrum disorder. for obvious reasons, that is just one of the presentation of autism. So even in seizures, those with blank stare, those with inattention, as I earlier said, loss of focus, they should be clear enough and present in such a way that they'll have a suspicion of a seizure. Difficult thing to do, but of course, an EEG sometimes can really help to diagnose that. Yeah.
Okay, thank you. Thank you for that. Is there like, should you look out for, is it 5 minutes, the stare? Is it like seconds? When should it concern you?
Seconds.
Seconds.
5 minutes is too long for us.
Okay.
So of course some people will have status, but 5 minutes is too long. So just like 10 seconds, 15 seconds, 30 seconds, that's the time. Yeah.
Okay, thank you. There's a question here.
And sometimes, sorry, maybe I just interrupt you a little. Sometimes they can also have some other manifestation. Maybe during the stare they can have some, maybe for example, like some eye movement, or maybe some drooling, so if they have such features during that time, then clearly that could be a seizure as well. So we need to have more symptoms. The blank stare can be accompanied by those things, and then now you can say this could be an epileptic seizure.
Okay.
Yeah.
Thank you for that.
Good evening.
Okay. Evening.
Yes, my name is Komora. I have a question. Can I go ahead?
Yes, please go ahead.
Okay. I'd like to know more about adult onset epilepsy. In autism. Adult onset epilepsy in autism. My son is now 26 years. We started the seizures when he was 22. And we are still, I think, on the journey. The challenge has been because he also is non-verbal ADHD. So with the medication, we have been seizure-free for almost 6 months now. But basically, his epilepsy we can't say it's not predictable. It goes 9 months, then he gets a seizure. Now it's been 6 months, we are going to the 7th month. So my challenge has been in terms of managing his other comorbidities, in terms of like he has what you call tics, constantly pacing. And so he's on 2 anti-epileptic, I think you took anti-seizure medications. So I've been trying to, we're under a neurologist and also a psychiatrist and a nurse. It's been quite a challenge trying to balance. Obviously, we don't try and touch the anti-seizure medicines, but we still have not stabilized him. He still has the tics. So I don't know what that means, and maybe I can get guidance on that. Thank you.
Okay, thank you. Maybe I ask a few questions, maybe the drug that he's using, and maybe, so if, I think number one, we have a fairly good control in what you're saying. So because it happens like one in over 6 months, one seizure in over 6 months, I don't know what really happens during the seizure. Is it a convulsive seizure, or are they the ones that present with, and when does it happen? Does it happen during sleep or during the day? Or
most have been during the day, though we've had, because as I mentioned, he started at 22 is when we got the first seizure, though he's been autistic all his life and non-verbal. So at 22, so we've, in total, actually, even if I say that they sound spaced now, in the beginning of last year, he had started getting them almost every 2 months. Then we had to increase one of the drugs, trileptal, between January and August. Then after August, we've not had seizures. So he's on a drug known as trileptal. And the other drug that I think it was added is clobazam. So those are the 2 medications he's been on. So from August to date now, we've been seizure-free, but on a higher dose of trileptal. Our challenge is still the movement, and now we've started noticing we're also not getting good sleep. 5 hours is up. If he sleeps at 7, by midnight 1, we are up till morning. So
Okay.
those are the main challenges that we are in a bit of a fix, but we don't want the seizures. We are not getting them, but we are not getting sleep.
Okay. Yeah, I think you've explained that very well. I think that's the right management for me. But of course, as I said, we always have to have some alternative. If it's not working well, then we need to change to see if we can have a better control. Clobazam is a fairly good drug. Trileptal 2 is a fairly good drug for seizures. And maybe for sleep, I will just maybe add a sleep pill, for example, like melatonin. Melatonin is a fairly good sleep pill that also allays anxiety in a way, and you can give it at night, and then we see what happens. It's just a trial again. Or night rest is also another good sleep pill, so but melatonin will be more advisable. Yeah.
Okay. Thank you.
Welcome.
Okay, thank you for that. There is also another question here. Kindly elaborate on autism, seizures, and aggression.
Autism, seizures, and aggression.
Yes.
Autism, I don't really get that, but I think maybe just to talk about aggression and seizures, there are some seizure types that can present with automatisms. So automatism will be something that can really be a behavior that you will think that is directed to you. So for example, somebody comes and hugs you, or somebody claps, or somebody picks up something, or somebody and tries to wear something. So sometimes that behavior can be aggressive a little bit, especially when you restrict them. When they start, maybe after a seizure, and they start walking and you restrict them, then they become more violent. And that could be a post-seizure effect, or sometimes it could be an automatism, a presentation of a seizure. So aggression happens in epilepsy. Yeah. Of course, in autism, it happens when you really, maybe you've offended them, maybe you've picked something from them when they are doing their own thing, and then you distract them. Then you can expect that they're going to have a little bit, they're going to be a little bit messy, sometimes really, really messy. Yeah.
So how do you manage this as a caregiver? When it happens, what do you do?
That's a difficult. I have a sister who has a child with SD, and we are now used to him. But the way we manage is we calm down normally. We normally redirect, very calmly, because when you use a lot of force, then it becomes even worse. So use as minimal force as possible. Just redirect, keep on redirecting until they calm down. And talk also slowly. Just follow them, At least for us, we've seen that it works. For when it comes to medicine, if really they are really anxious, maybe they are all over. Sometimes there are some medicine that can be tried. For example, risperidone. There are some people who have been tried on risperidone, and they have allayed the anxiety. They become a little bit calm. If they have ADHD, some stimulants, for example, methylphenidate, that also makes them a little bit, focused. Yeah.
Okay, thank you. I hope that answers. Is that satisfactory, Geoffrey? Okay, as we get to Geoffrey, we can move on to the next question. How often should EEG be repeated when a new diagnosis is given? And maybe when we are at it, Dr. Please elaborate what EEG is to a first-time caregiver and what that looks like.
Okay. Okay. So an EEG is a test that checks the electrical activity of the brain. So what basically it does, it looks at the functional abnormality or in patients with epilepsy. So what happens is we put wires and then it records some waves, and the waves can tell us whether that wave has an epilepsy feature or not. But it also tells us other stories apart from epileptic abnormalities. So, for example, if it's too slow, it can say that probably the person has intellectual disability or something. So that test, it's only done once because there are several reasons why we do an EEG test. So the first reason, number one, for an EEG is when we want to diagnose epilepsy. There are some seizures that are too difficult to, you're not sure whether that seizure, you are very sure that what happens is that is a paroxysmal event. I mean, it's a seizure, very sure that this is a seizure, but I'm not sure whether this seizure is epilepsy or not epilepsy. It's sort of like you're not sure. This blank stare that takes like 30 seconds. But something else happens. Sometimes I sort of like touch him and then he responds, sometimes not, sometimes, so you're not sure. And it's just that thing that happens. Then an EEG will be able to help tell us whether that event, whether that seizure is epilepsy or not epilepsy. Sometimes you do an EEG, we know that this is epilepsy, but we want to classify the type. We want to know, where is this seizure coming from? Is it coming from left side of the brain, the right side of the brain, the frontal part, or whatever part of the brain? That helps us also to come up with a better treatment plan. And another reason for diagnosis is when we want to diagnose what we call epilepsy syndrome. For example, like the one that I presented, the acquired epileptic aphasia, the one that presents like, which has autistic features, not very many seizures, but a child suddenly starts having communication or language problems, and then they have behavioral problems, and then they have few seizures, and then when you do an EEG, you will really find, very characteristic findings that will say that this is Landau Kleffner syndrome, and therefore this is the medicine, because that particular type of epilepsy can be treated with steroids and responds very well to treatment. So over time, the child starts acquiring again language, starts behaving, in a better way. So EEG also helps us in that. And then in terms of treatment, EEG helps us to understand what is the best anti-seizure medication for this type of epilepsy, because we will have diagnosed that. Sometimes it can help us understand what could be the problem in terms of, if the patient is deteriorating in terms of cognitive function, then what could be the problem? What is happening? Is this person having many seizures, or what is it? Is this patient having non-epileptic non-convulsive seizures? So EEG can help us to answer, such questions, and also sometimes also help us to understand those features, whether these patients can go for surgical treatment for epilepsy. It can also help us sometimes when we are stopping anti-epileptic drugs, but this should not be taken like 100% of it, but it helps us, when we are stopping anti-seizure medication, what is the risk of further recurrence after stopping anti-seizure medication? Yes, so that's what EEG is, and those are the indications for an EEG. So you don't need to repeat it many times. If you have a diagnosis, that's it. But if there's deterioration of cognitive function, if there's deterioration if there's chronically the patient is not improving, and maybe there's something new that is developing, the EEG can help. Yeah.
Okay, thank you. Thank you very much for that. Maybe I'll combine your last statement with the question. My autistic son, 3.5, had no eye contact. After occupational therapy, eye contact came. It has disappeared again and is still doing therapy. How can I get his eye contact back?
Wow. Therapy. I think I think that's what happens also in autism. Sometimes they can have some words and then those words disappear, and then have some words and then they disappear. Sometimes they can have that eye contact and then it disappears and then have it again. So let's keep on having therapy. Yeah.
Okay.
Don't give up on therapy.
Okay. Thank you. Thank you for that. Does puberty affect autistic people, maybe considering changes in hormones in the body?
Yeah, I would guess so. And I also need to hear this from parents, the experiences. But of course, yes, even in epilepsy, epilepsy and autism during puberty, because of the hormonal changes, some of them really affects them badly. Seizures also increase. And sometimes some of the behaviors also, worsen. So it can affect. And I want to probably hear from the experiences of parents, what they've experienced. My cousin's son, he's not yet puberty. So we are not yet there. I don't have that experience yet. I don't know what is going to happen when he reaches that age. Yeah. But of course, it can affect. And probably I think some parents here have experiences, probably they can share and learn from each other when it comes to that.
Okay, thank you. I'd like to open the floor to a parent who has, a child at this stage, to just give in a word. Does puberty affect autistic people? Maybe considering changes in hormones in the body. What has your experience been as a caregiver? For those of us who have reached that stage, what would you say? Let me, Jane, let me kindly open the floor for us. Since you have been there, what's your take on it? Does puberty affect autistic people?
On my side, can you hear me?
Yes, we can.
Okay, thank you for the question, Carol. Well, I think I've passed through that, through my sister's daughter and my son. It does affect them. They're just normal. They're just like these other people when it comes to that. Because what I saw in my son, maybe he used to see the cousins, the way they cut their hairs, their hairstyles, maybe how they behave, what they talk. So it affects them. They want to be like them and they want to do all those things that puberty people do. Like my sister's daughter who is epileptic. There's a time when she so much wanted to have a baby, go through that, just like any other person. It affects them. That's all I can add on that.
Thank you for that.
Thank you.
Is there anyone else who can also share their experience a little bit on this question?
Could I kindly ask a question?
Oh, okay.
Thank you, Doc, for that insight. Just something I have been trying to observe.
Yes, please go ahead.
Yes, we can hear you.
Kindly go ahead. Okay, as we wait. Florence, you can hear us? Okay, as we wait for Florence to ask the question, is there someone else with a question? Okay, as we wait for Florence, let me engage you a bit, Dr. Eddie, you know, we want to demystify myths and the truth. So allow me to ask you whether it's a myth or a truth, even as we wait for Florence to plug in and ask her question, or anybody else as well. So one of it is on triggers of seizures. Is lack of sleep a trigger? Is it a myth or is it true?
Hi, thank you. So lack of sleep is a trigger for seizures. It's not a myth.
Okay.
But not all people will have the same triggers. There are some people who will have different triggers, and there are some people who have special, sensations and feelings, as their triggers. And some you'll never ever find in books. They'll just tell you. For example, people who are triggered by certain music or reading epilepsy, for example, it's not that when you read everything, you get a seizure. Or musicogenic epilepsy, for example, not all music will trigger seizures. So there's this young lady who I know, her trigger was the music from bongo. So the bongo music will trigger her seizures. And it took so many years to understand that. But that was very true. By the time we knew that, it was true that this type of music would trigger her seizures. So reflex epilepsy also happens. I know there are people who, when you touch the big toe, they will have seizures. Of course, they have other coexisting morbidities, but that happens. So I think the most important thing is to learn ourselves, to learn our relatives, our children, what triggers these episodes. And when you know that, and when you avoid that, then at least you'll be a step further. Other than increasing medicine every time you go to the doctor, and you tell them he's had 2 seizures, and then you increase medicine. Maybe he didn't sleep well last night. Maybe he had a scare or something. Maybe if it's a lady, maybe they were on their, menses. Maybe they were, something that probably, maybe they didn't even drink well or eat well, or maybe they have an infection that is silent, So I think, and triggers are there. So I think it's important to learn our triggers. Yeah.
Okay. As I'm about to bring in Florence, I have 2 more. Fever, high fever. Can it be a trigger? Is it a myth or not?
High fever is a trigger, especially for children. It can trigger seizures. Yeah.
Okay. What about change of timings in giving medication?
Yes, that's a big trigger. That's a big trigger. Stick to your time. If it's don't say no, I'll take it tomorrow, or you miss, or or today you take at 7 a.m., tomorrow you take at 10 a.m., the next day you take at 8 a.m., the other day you take at, anti-seizure meds don't work that way. Yeah.
So you must stick with the time frame that you're supposed to. So
yes, so if it's 12 hourly, it has to be 12 hourly. So every day, if you take your meds at 8 in the morning, 8 in the evening, 8 in the morning, 8 in the evening, or 7 in the morning, 7 in the evening, put reminders, maybe through your phone, through something, maybe relatives, brothers, sisters, who can always remind you to take your meds at that time. Yeah.
Okay, thank you. Thank you for that. Let me bring in Florence. She's back. Florence, please ask the question.
Yeah, sorry, I lost my connection. So I was asking, my daughter is about 3 years, 3 months on autism level 1. So they have been going for therapy as a school. Initially, we would take her alone for over a year. Then now, this second year, they have been going with the school. And they are mixed. There are kids with autism and there are those with Down syndrome. So over time, I have been keen and observing and even taking notes. Then one thing came out very common, that on the specific days that they go for therapy as a school, she gets these sensory overloads at night. So she would have these weird behaviors, throwing things, putting her hands in her mouth and removing saliva. We would take ages to go to bed despite her being on melatonin. So I was wondering, could it be possible that they copy what they see? Or am I overthinking? Just probably if I could be able to get anything in relation to that kindly.
Thank you. Florence, I think there must be a relationship to that, because if that happens every time they go for therapy, then there could be a relationship. Whether it's imitating, whether it's a stress-related, feature, honestly, I can't figure it out for now. But I think it's related because of the pattern and the way you are describing what really happens.
Okay. So probably what could we explore, Doc? We probably try taking her for therapy alone without involving the other kids in the school, maybe to monitor?
Yeah, maybe you need to monitor first what happens, during therapy in the group session, when they go together, and then observe really what happens there. And then probably you can see if there are some things that, can be changed. And then if it doesn't work, then maybe she can go along. But I think first we need to observe what really happens there.
Yeah. Okay. Thank you.
Thank you.
Okay, thank you for that question. Is there anyone else who has a question? Please feel free. You can send a text or just unmute yourself. So as we wait for another question, let's talk about overdosing. For instance, maybe a caregiver in a household, probably you're supposed to give medication at 6 p.m. And one caregiver came in, maybe a mother was late to come and give a father. And when the other person comes in, maybe at 8, they also give, thinking that the other person did not give. What happens in such a case?
Yeah, I think that it actually depends on the dose. Some doses can be really, toxic if they're on high doses. So maybe if that happens, you can check with your doctor or your nurse immediately and see if it's not. For example, I'll give an example. If for example, if you're giving something like Epilepsy, for example, and the dose you are using is 400 milligrams per day. And then on that particular day, you use like 600. Maybe you use 200 in the morning, but you've used 200 and 200. That won't be much toxic. Maybe what is going to happen is the child is just going to get drowsy or a little bit irritable, and then after that, they'll be okay. So I think it depends on the dose, but the doses, if are very high, then you need to take them to hospital, at least for observation for a few hours, and then.
Okay, thank you. Thank you for that. The reason I'm asking, because we've encountered that. So we needed to hear also from a professional what should be done. Yeah.
Okay.
I also want to bring in a question on sports. Are there some sports that our children, maybe with epilepsy, should not engage in, or should, is it open? Are there some risky sports that you can highlight to a caregiver?
Wow. I think that's a good. I think when it comes to sports, we just need to be careful, because sports that probably are very physical, it can be dangerous. So maybe we need to explore. We need to to do the sports that are not very, very physical. But I know there are some people who have epilepsy and autism, and they do very physical sports. They play football, for example, and sometimes football can really be physical, and they are very good at it, and they enjoy it very much. So I think it depends also in the ability of that particular person, and more importantly, if it doesn't trigger them, to get seizures, or to get very irritable at night, or not sleep well at night, why not? I think what really works for you, so long as it's not going to be dangerous, it's not going to cause more harm, it's not going to interfere with your physique, then I think sports is important for all of us.
Okay, thank you for that. There has, is that a question? Okay, there's been this school of thought on swimming. That is what the background of this question. There has been this discussion on being very careful when children with epilepsy, autism and epilepsy go to swim. Should they not? It's been contentious a bit.
Yeah, I know. apparently, if you're well controlled, and you have all the gears, then we don't restrict people with epilepsy not to go to swim. So long as they are well controlled. If you have frequent seizures, that's not advisable, of course. But if your seizures are not very frequent, and of course you must have all the gears. If it's a life vest, and then somebody should also swimming beside you. Just in the unlikely event, something happens, then somebody can also help you. We had an epilepsy. Sorry, we call it a Pigambizi. Pigambizi is one of the events where people with epilepsy do swimming competition. So, but of course, they are well controlled, and we have all the measures taken. So they enjoy it very much. Yeah. So don't go alone, and don't go without a life vest. Even if you know how to swim, but the person with epilepsy must also have a life vest.
Okay, thank you for that. There's a request for your contacts in the chat section, so that somebody who'd like to reach out to you can reach out to you. How do you want them to reach out to you?
Okay, let me write.
Okay. Well, we are on that. I'm thinking about the caregiver who is in the rural areas and wants to get a diagnosis, notices something is off. where should these caregivers start in terms of seeking for help, where there are no specialists?
Yeah, now, something good is happening in Kenya, and it starts with what you're doing already, the gifted gems, This is amazing. I'm very excited. What you're doing is great. So I think we need to create more awareness. And what is happening, especially in some counties, for example, like Kilifi County and other counties, we normally have organizations that train, health professionals on what we call MH gap, or mental health gap. There's a manual for diagnosis and management of neurodevelopmental disorders, both in children and adults as well. So I think don't hesitate to take your child to treatment, to the nearest health facility, level 2, if you like, at the dispensary level. Those people, if they are not trained, the government has a very good referral system. Of course, I know people will say, no, I've gone there, they were this and that, but the protocol is clear that if you can't manage at the dispensary level, take them to level 3, level 4, until it reaches at the county hospital levels, where all the specialists can be found there. So many a times we'll find specialists at the county hospital levels, because private hospitals, again, are very, very expensive, and most of the people cannot afford to pay for those services. So so number one, go to the dispensary level. If they can't manage, they'll refer you appropriately.
Okay, thank you for that. Then there are times that you could be with a child and suddenly the child falls and stiffens. What do you do from there? How do you manage that that condition so that the child does not choke or him or herself?
Okay. So that's the first aid, and I think Jen was saying that they used to put a spoon, and yeah, thank God, the education is on, and I'm very glad that they know that that's not right. So number one thing is, don't panic. Because when you panic, what happens is you're not going to help this person. Of course, it's very scary when all of a sudden somebody falls, stiffens, because what comes into our minds when that happens is this person is dying. I once asked a parent, like, how does your child fit? And she was like, are you serious? Why are you asking me that question? So she was like, have you ever slaughtered a chicken or a goat? Have you seen this chicken, the way it does when it's dying? So that's what my son does. That's what my child does. So clearly they're telling you it's a near-death experience. It's like, it's that bad, and that can cause panic. So number one, don't panic. Number two, make sure that the environment is safe. So keep safe. If there's something that can harm, this child, make sure that, it's you've removed that thing. So many a times you want to hold the head so that they don't keep on, crushing the head on the ground. Sometimes it can cause even more injuries to the head. So you can use your hands, to hold the head. Make sure that you untie everything. So if, for example, they're having a tie, you can remove the tie. If they're having some glasses on their eyes, remove things that can probably cause more injuries. And then make them lie on the side as well. Because when you let them lie facing upward, they are more likely to choke. So when they are frothing, or maybe they have bitten their tongue and blood is coming out, they can easily choke. So what happens when you put them on the side, then that blood will come out from the side and you'll be able to, to wipe it out with tilting the head a little bit up. Then don't restrain them from having that movement. If they're jerking, for example, don't restrain them. Let them jerk, so long as they don't hurt themselves. So you may need to use light force to but not a lot of force to restrain them. You can even injure them. You can even break their bones because they're using a lot of force to jerk, and then you are restraining them. So you're using more energy than them, so you can hurt them badly. So another thing is, don't put anything in the mouth and don't give anything to drink or eat until they fully gain consciousness. And then after that, talk to them like now, a good voice, a reassuring voice. If it's your son, call him by name, reassure him that you're with them, Eddie, I'm with you, you've just had a seizure, but it's okay. What are you feeling? Do you need something? Just a voice that is reassuring, because sometimes when they wake up, we're all in a panicky mood and the patient feels like, what really happened? Somebody stole my time and everybody's panicking now. Was I dying? And then it causes even more distress. So that's first aid for seizures.
Wow, thank you. When you're explaining it that way, it sounds, like it's so easy, but I can feel the caregiver. Yeah, but it's good to arm ourselves with knowledge. So to just maybe reiterate what you've said is to just make sure that you don't panic.
Mm-hmm.
That's the first step.
Yes.
Then you before you put them on the side, you tilt. I don't know. I think
you don't panic. Make sure that they are safe. So remove everything that can injure them. You can put your hands below below their head. Don't restrain them. Untie. If they have something that is tight on their neck, you can untie. You can loosen that. Or if they have glasses sometimes on the eyes, remove, because that can also injure them. So just need to keep that environment as safe as possible. Yes. And then of course, no restraining. Don't hold them on the ground. So that can really injure them. Yeah.
Okay, thank you very much.
Of course, it's not easy. It's not easy, Carol. It's not easy at all. It's easier said than done. Yeah.
True that. So I want to just go back to our participants. Is there anyone else with the question? We are slowly coming to the end. We're slowly coming to the end, or is there any one of us with a comment?
Can I make a request?
Yes, please.
I had a challenge on the network and really wanted to be guided on how to handle an autistic kid. Yeah, I don't know whether I can be given a summary, just a kind of consideration, because my net went off completely.
It's okay, just ask.
I don't know what was covered, but I don't, so I can only ask when they have this, we call it like baby talk, they just talk and throwing a tantrum. What intervention can someone do?
I didn't get that clearly. In terms of what intervention? In terms of
as a caregiver,
yes,
when they are ni kama anajiongelesha.
mtoto anajiongelesha.
Anajiongelesha, anajichekesha. Ni hii challenge ya autism.
Naelewa.
What intervention can you do? Mtoto anakuja tu anajichekesha tu for long, and how am I supposed to intervene?
Okay, sawa. Naelewa. So unaona hizo ndio huwa ni dalili za hiyo ugonjwa. Na hiyo therapy ambao huwa hiyo behavioral therapy na hizo cognitive therapy ambazo wazazi wanaenda katika sehemu tofauti tofauti, huwa inaweza kuwasaidia kufanya kitu kimoja baada ya kitu nyingine. Sasa mimi naelewa, unaona kama sahihi, wewe unaona concern yako ni hiyo kuongea na kujichekesha. Na hiyo ni muhimu, yule mtu ambaye atakuwa anaona mtoto wako Rose unamwelezea ili aelewe, alafu akwambie hii step hii tutaifika wakati fulani, saa hii tutaangalia hii, saa hii tutaangalia ile, saa hii tutafanya hivi na vile. So I think it's step by step, but that can be addressed probably by the behavioral therapist, and some of the symptoms happen. For example, the eye contact. Kuna mzazi mwingine amesema mtoto wake alikuwa akimwangalia, saa hii hawezi tena kumwangalia. So bado ni hiyo therapy itaendelea hivyo polepole, pengine ataanza tena kumwangalia. Wengine wana hizo repetitive movements, anafanya kitu the same. Hata ukibadilisha barabara, kama kila siku amezoea tunapita na hii njia, hauwezi badilisha hiyo njia, lazima mupite na hiyo njia. Ukibadilisha inakuwa ni shida. So hivyo hizo ndizo ambazo ni dalili ambazo tumeziongea, na hizo therapy tunafundishwa jinsi ambavyo tunasonga mbele moja baada ya nyingine. Yeah.
Okay, thank you. And just to ask, was this recorded that somebody can access or maybe contact for the facilitators?
Yes, it's recorded.
Yes.
And the contacts are in the chat, but we can read them out as well.
Be helpful because I don't think I can trace those because I was thrown out by the net.
Sorry about that. The telephone number is 0723 647 630. 0723 647 630. We are recording as well. We'll be sharing the link in our various emails so that we can get time and just go through it once more. Just to maybe reiterate what you've just been told, most children do that. And yes, therapy helps. And consistent therapy and just talking to the therapists working with you. I know ABA therapists are not very common. Ama mkona wao in your area, ABA therapists wako very common.
What does ABA means?
Applied behavior analysis. So what we can do you have a speech therapist near? Mnafanya speech therapy?
Yes.
Okay. Na occupational therapy?
Yes.
Okay. Maybe having and any other caregiver also who has been through that can also add in. Working with the therapists, wale wako karibu na kuambia what is going on, they will help. They can help in addressing that. Wakuonyeshe mbinu ya what to do.
Okay.
Yeah. Wakati mwingine pia, I think even as caregivers, sometimes when mko na yeye nothing is working and it's not self-harming, sometimes you just let it slide. But when therapy is on and umeonyeshwa what to do, it also helps. Because najua it happens anytime, anywhere, si ndio?
Na watu wanakuangalia wanashindwa ni nini?
We hear you. We hear you. Many of us, including myself, we go through something similar to that. Yeah. Thank you. Thank you for the question. Is there anyone else who would have an input on that? This is your...
Hello.
Yes, please.
Yeah, mine is just to add on the same question that caregiver has been asked. I have the same problem, and mine has really gone up because maybe I didn't work on it at the right time. He shouts a lot. Like the other day, I took him for a dental clinic, whatever, we were going somewhere around. Until we were so confused, we were not able to do what we were doing because He was very rowdy, making a lot of noise. He did not even rest even a minute. So everything becomes so bad. You can't even do what you went to do there.
We hear you. We hear you, Jane. Is there one of us who also has a tip on what we can do when you're in such a situation? Judge, I don't know whether it is the same Judge. Could I kindly click on you to say something?
Hi, Grace.
Um,
Hello.
Hi, Judge. Karibu.
Asante sana. I've just gotten in. Wacha nisikize kenye wanasema. I'll give my contribution as we conclude.
Okay, thank you. Maybe you can take that again. Let me just have the concern was about having a child with autism laughing, uncontrollably in certain situations. Then you could also explain what you were saying. Then and the other caregiver and judge can also say something about it. Then you could ask your question. You could give the comment again. Our previous caregiver.
I can go first. I was asking, I got a kid who has a autism issue. So yani anajichekesha, anaweza kuwa amekaa, anaanza kucheka. Na anacheka for long. Then ni kama ni kuswing the head backward out of the blue ama ajiogereshe. Sometime uko mahali ni public, watu wanakuangalia, unashindwa, now what am I supposed to do? What intervention can I do? You try telling him, please talk to me. But at that particular time, he is in his own world. Rarely does he respond to that request. So I was asking if there is any intervention should I do? Thank you.
We hear you. We hear you. So, Judge, that is almost the same scenario also with Jane.
Okay, can I give a response?
Yes, please. And maybe introduce yourself for context so that they can know who you are.
Oh, my name is George. I'm a specialist in matters pertaining disability. So in connection with that, I also do assessments. So thank you very much for the session. I know you've learned a lot. So just to delve in what my colleague is talking about, is that we understand that children with disability, more so autism, that has been asked on, we understand that they always belong in a different spectrum. So what we need to do, what all the caregivers have to do, is to understand your child, understand the psychology of the child, because we know there are behaviors that are learned and there are some behaviors that are always unlearned. So for example, with autism, they're always used to copying and imitating what is happening within the environment. So it is upon the caregiver to check on what kind of behavior is good for your child. Which kind of a behavior should you strengthen and which one should be weakened? So for example, like in a scenario that we've been given here, this child is always smiling at him or herself. You need to understand what makes this. I came in when Grace was trying to explain the ABA. There is also another one we call the ABC. the antecedent behavior and the consequence. Antecedent here means what triggers a behavior to take place. Then the B refers to the behavior itself. And then the consequence, what will happen after the behavior. So if this child laughs at himself, you need to understand what triggers the laughing. So you need to analyze that before he smiles at himself. What happens? After that, now you will now try and remove the triggers, that the external factors that triggers the behavior. The second thing, the mirror that we have in our houses. A mirror is a very good example of a therapeutic agent. For example, when the child is smiling at himself, just try and bring that mirror closer to them. They will look at themselves. There is something that will change. So the mirror helps in improving the self-esteem. Thank you, Grace.
Okay, thank you, George, for that. I hope it sheds a little bit of more light to our caregivers and to all of us. So we have 5 minutes to 8. Is there any other question, or should we bring this to a close? If there is, this is the moment.
Sorry, can I speak, please?
Yes, please.
My name is Rosemary,
Okay.
autism teacher.
Okay.
I've heard what my sister is talking about. She's talking about the child laughing all the time, and also what she has talked about. We have something that we call obsessive compulsive behavior. A child may tend to laugh, others may tend to cry all the time. So when you realize such a behavior is happening to a kid, you need to see a therapist. I've heard you talk of ABA and ABC, which is okay. You go and explain to them, or you have an expert who is going to help you control that. They're going to guide you on how to control such behaviors. There are those who laugh and others cry. That is the characteristics of children with autism. When you talk about meltdown, it happens because something has triggered it. So you need to realize that what has triggered the meltdown, so that you can take away or control what is making the child behave that way. Thank you.
Thank you. Thank you very much for that insight. We do appreciate that. Well, we are still discussing that. There is a comment here. My son becomes a problem when he sees a lot of people. So maybe could that be a trigger? Let me go back to you, Rosemary. Could we classify it as a trigger?
I didn't hear quite well. The sound was very low. What was the trigger again?
There's a comment here. My son becomes a problem when he sees a lot of people. So maybe
It
crowds.
Fear of a crowd. You need to do something called desensitization. And how do you do desensitization? You introduce 2 people to the kid. You go adding 3 people, 5 people, 10 people. By the time you are through, the kid will have gotten the bigger picture of a crowd, and that fear stops. The best thing to do to such a situation, you do desensitization.
Well, thank you. Thank you for that. Thank you for that. Yes, we appreciate every insight. And now, please give a last comment, Dr. Eddie Chengo.
I just want to thank you all for this opportunity. I don't take it for granted to share, and of course, learning from all of us. So my last comment will be the children with autism, with epilepsy, or autism and epilepsy, or any other neurodevelopmental disorder, they are still people. And I think that is how we should treat them. We should treat them with, the energy that we have, with the respect. I understand it's difficult, but they are people, and they have something, in them that really needs that respect. And I think when we view it from that angle, then we'll be able to support them in so many ways. We need to learn. A lot of research needs to be done in epilepsy and autism, the occurrence of epilepsy and autism, the genetics issue, of course, that will help us in understanding how we can prevent, such conditions. Yeah, otherwise, thank you very much, and God bless you all.
Thank you. Thank you so much. We'd now like to just bring this to an end. We just want to thank every last one of you. Thank you very much, Dr. Eddie Chengo. Thank you very much for every last one of us who has participated in one or the other. Even being here, you've said something, you've listened, you have given of your time to learn. Thank you very much. And we pray that God will bless you, and even as caregivers, give you more strength and more grace as we walk through this journey. And may the peace of God just be with you. Thank you so much to every last one of us. So we'd like to close with a word of prayer, and allow me to close with a word of prayer right now. Lord, we thank you for this beautiful evening. Thank you for the session that we've just had and the learning that we have had. And we pray that, Lord, you will help us make informed decisions, even pertaining our loved ones. May you give us peace as caregivers. Those who are at a point, oh God, that are so low, may you just encourage them. May you provide where there is a need for provision. May you visit with each and every household represented here, and who will even listen to this and watch later. In Jesus' name we pray.
Amen.
So thank you very much. God bless you.
Bless you too. And have a good night.
Yes.
Good night.
Good night. Thank you.
Good night.
Okay, we shall, docs number, let me read it out again. Let me just read it out again. 0723 647 630. 0723 647 630. Thank you very much. Good night to everyone.
Thank you. Good night. God bless you.
Okay, you too.
Doctor.
Wow.